behalf of McLaren Macomb, hello and welcome to this educational program on structural heart disease. I am Kelly DiNardo, your moderator today, and we will be hearing from Dr. J. Mohan, an interventional cardiology specialist at the McLaren Cardiovascular Institute. At the end of the presentation, Dr. Mohan will be answering any questions that you have, but we ask that you please use the chat feature to send in your questions. And if you could also use the chat feature just to enter your name so I could check for attendance, we would appreciate that. So with that, I will turn it over to Dr. Mohan, and thank you so much for speaking with us today.
Kelly, thank you for that nice introduction, and I welcome all of you guys to a hopefully exciting talk on structural heart disease. My name is Jay Mohan. I'm an interventional cardiologist at the McLaren Cardiovascular Institute, primarily at McLaren Macomb Hospital. And it's my pleasure today to speak to you about the wonderful world of structural heart disease, what it entails, and what we should do about it. So, when we talk about structural heart disease, what exactly are we talking about? So, being from the Motor City, I like to think of the heart like a car engine. And so it's besides the brain, probably the most important organ of our bodies. It works and beats thousands and millions of times throughout our lives. And even though you can take care of your heart over a long period of time, just like a car engine, things are going to start to wear and tear regarding that engine or your heart. And so structural heart disease really refers to things that have occurred in your heart over a course of time, and the normal wear and tear and what happens to certain aspects of your heart as we all get older. And we'll talk more about that shortly. What to look out for, I'm going to talk about this more, but specifically warning systems that everyone on this video can, hopefully look out for, but also what your doctor should be checking for whenever you see them. And what's really interesting about structural heart disease is a lot of the stuff that I'm going to talk about today was not able to be treated until, very recently, probably in the last 10 to 15 years. This is such a new field, and it's so exciting because we can not only offer people that had no options in the past, but we have options for, instead of going through open heart surgery, you can actually go through a minimally invasive procedure and potentially go home, after one day versus a long, sometimes high risk surgery. And the other part about this is it's really brought together two amazing fields, one being interventional cardiology and general cardiology, and the other field being cardiothoracic surgery. And working with our amazing surgical colleagues, we're able to offer the best treatment option to our patients, whether it be open heart surgery or some sort of catheter-based structural intervention. So to start, how does structural heart disease affect the heart? And I thought this video is great because it's kind of a whirlwind tour as we enter the heart. So I'm going to talk about what we're doing here. So we're going through one of the biggest valves in the heart called the mitral valve, as you see on the right. And you enter the main pumping chamber of the heart called the left ventricle. And as you can see here, the valves aren't just, they're very complex structures. They're composed of a subvalvular apparatus and multiple pieces of tissue. And then as you exit the heart, you go through a 3-leaflet structure called the aortic valve. And the aortic valve is the big doorway to the rest of the body. And here we are going through the rest of the body to the brain, the kidneys, the liver, to your legs. And that's how basically the heart works. And when we talk about structural heart disease, there's many aspects of this, but the most important part that, in my opinion, of structural heart disease is the valves. And so there are 4 valves of the heart, and specifically the 2 that we focus on most in structural heart disease, and the 2 that generally get the most wear and tear as we all get older are the mitral valve and the aortic valve, and those are the 2 that you saw in that video. So whenever you talk about valves, I always tell my patients, think about it as a door. So, you have your big pumping chamber of your heart, And that's every time your heart pumps, it pumps and it goes through doorways. So the doors either they open and they close throughout our lives. They do that millions and millions of times. Over a long period of time, calcium can build up on those doorways and they can become stuck closed. And that's something called stenosis, where every time the heart pumps, you have to generate a big force of pressure to open that door because it's stuck closed. Sometimes over time that those doorways can become a little bit pulled apart and they can sometimes become regurgitant, or every time the heart pumps, blood goes forward, but instead of the door closing all the way, it's left a little bit open and blood can flow back. Both of those things can affect the efficiency of the heart, and they can cause different things to happen, but most severe and what we worry about the most is something called congestive heart failure. Another portion of structural heart disease that I feel people don't really talk much about, but it is an important thing, and we're hearing more and more about it, is a lot of strokes that people encounter and they come into the hospital. We're actually finding they originate in the heart, specifically from arrhythmias like atrial fibrillation or from certain defects in the heart that are remnant from when we were all born, but specifically things like atrial septal defects or patent foraminal valleys, which are basically fancy terms for holes in the heart, in which little micro clots that form in the leg, they can actually shunt across those holes and go, and the heart pumps them and they go to the brain and they can cause a severely debilitating stroke.
Your computer, it keeps blinking on the screen that you're showing us, so it's hard to read it, and it's kind of annoying, taking away from paying attention to. Is there some connection problem at your end that it's just blinking all the time?
Let me see if I can do this. Is that better?
No, it's still blinking again.
It's coming through fine on my screen, so it might be your connection there, Sharon.
Oh, maybe. Okay.
It's clear on my screen as well.
Okay.
So what do we want to look out for people that are encountering structural heart disease? So structural heart disease affects many different parts of the heart. So the symptoms can be very wide. And so what I like to say to my patients is the number one symptom that I notice the most and kind of the earliest warning system is shortness of breath. And what I always hear patients tell me is, Doc, I'm getting older. This is just a normal wear and tear of me being older. I just feel short of breath. And I always tell them that that's not true. What you should be able to do everything that you were doing 5 years ago. You shouldn't be limited by being short of breath unless something has changed. So don't just think, oh, I'm getting older and this is the way I'm supposed to feel, because you'll be very surprised that a lot of the symptoms you may be feeling could be originating from your heart. And if we correct them, they could go away. So other things, obviously chest pain is a very ominous sign and things you want to worry for, but things like dizziness, leg swelling, nausea, lack of appetite, and just generally feeling fatigued can also be warning signs that there may be something wrong with your heart, and specifically something structurally wrong with your heart. So the diagnosis. So this is on the video on the right is actually a very interesting procedure, is where we actually go in and replace your mitral valve through a transcatheter procedure, and we can replace that valve through your leg and deploy a valve similar to what you see on the right. But what's really unique about this video is that it's a example of three-dimensional echocardiography, which that is probably the hallmark way to or gold standard way to diagnose structural heart disease. But what I think most people, if you have any worry that you may have underlying heart disease, the first thing you should do is talk to your primary care physician. Make sure that you're getting your annual physical. Make sure that you're being very truthful with your symptoms. So if you feel short of breath and fatigued and don't just blame it to being, I'm 70 and this is the way I feel. That's something you should let someone know about, because what it does is it clues us in to look for specific things. Other things to look out for are, on annual lab work. If your kidney function or liver function are abnormal, there must be a reason for that. And sometimes it can be due to a failing heart. And then once your primary care physician thinks that there is something wrong with your heart, they'll send you to a cardiologist. And the cardiologist is trained to specifically look for aspects of structural heart disease. And one of the biggest ways is with the use of a stethoscope. And just listening to your heart with the stethoscope can clue us in that maybe one of your heart valves is leaking, or maybe one of them is tight. And simple things like that lead us to doing things like advanced imaging, like what you see on the right, which is something called echocardiography. But other technology like CT scan and cardiac MRI have started to come down the pipeline, which has really helped us plan and assess for people with structural heart disease. So getting into the realm of structural heart disease, I thought I would start with the probably the number one thing that we perform, and probably the number one procedure that's kind of put structural heart disease on the map. And it's something called transcatheter aortic valve replacement, or TAVR. Basically what that is your heart is like the big pumping chamber of your heart pumps through a door called the aortic valve. Every time your heart pumps, the aortic valve opens and it closes. It opens and it closes. Over a long period of time, as we all get older, it's a natural progression of just getting older, the valve starts to develop calcium on it. So every time the heart pumps, that heart valve, it takes a lot of work to get that heart to open, or that valve to open. So the heart's generating a lot of pressure to open the valve. And over time, just like any muscle in the body, if you lift a lot of weights, the heart's going to start to hypertrophy or thicken, and that decreases the area within the heart to fill. And over time, that heart is going to fail, and it's going to lead to congestive heart failure. So 20 years ago, the only way to fix aortic stenosis was through open heart surgery. And many patients didn't present until they were 70, 80, 90 years old. And a lot of 80 and 90-year-old patients, they can't go through the trauma of having their sternum opened and going through a long recovery with bypass surgery. So transcatheter aortic valve replacement has actually taken the place for a lot of these patients for open heart surgery. And what it is it's a minimally invasive procedure where a cardiologist will go in through your leg artery and deploy a valve with a balloon, just like we do with stents. And that valve is deployed in the aortic position, and it actually replaces that aortic stenosis that you have. And it's indicated for people with severe aortic stenosis, primarily for people with intermediate or high risk, or people that can't go through surgery. But it's now moving towards more lower risk patients. And access is usually obtained in your leg artery. You come in as an outpatient, and you can actually be discharged the next day after this procedure. So it's been very, very unique in that we can correct a heart valve in one day and take something that's making you feel so poorly for so long and make you feel very good pretty immediately. And the recovery process is so awesome, is that you come in as an outpatient, you're home the next day. And we work with our cardiothoracic surgeries in tandem. And so there's a long process to work you up for a TAVR. You go through some testing, and we make sure that we offer you the best approach. Surgical is still the gold standard. So people that qualify for surgery, they still do very well, but a lot of people don't. So we at least have this option to provide to our patients if you can't go through open heart surgery. The next procedure, which is probably the second after transcatheter aortic valve replacement, is something called the Watchman procedure. So like I said earlier, one of the things we've really realized is one of the biggest causes of stroke is strokes originating from the heart. And I always tell my patients that strokes can be one of the most debilitating things that occur in your life. You can live your whole life and then all of a sudden you have a stroke and you're bedbound and you can't, take care of yourself anymore. So really controlling this ability to reduce your risk of stroke is very important. And one of those things that we find with a lot of our patients is they have something called atrial fibrillation. What that is where the heart doesn't exactly beat correctly, and the top chambers of the heart, they kind of fibrillate, and that leads to blood clotting to form within the heart. And so a lot of these patients with atrial fibrillation, they require long-term blood thinners to prevent the risk of stroke. So blood thinners work very well. The issue with them is that over a long period of time, you can develop bleeding issues. Say you fall and hit your head and you bleed in your brain, or say you have blood in your stool, or you bleed into one of your joints. All of these things decrease your ability for long-term blood thinners. So what this procedure is where we can bring you in as an outpatient once again, and go in and close off this area of the heart that we've found that causes the most amount of strokes. And we place this device, like you see here on the right, in that area called the left atrial appendage, and we can close off that hole, and that basically will reduce your risk of stroke the rest of your life, and it also takes away the need for being on long-term anticoagulation or blood thinners. We work in close collaboration with our electrophysiology colleagues. And it's, once again, you come in as an outpatient, and actually we've started discharging our patients home the same day. So it's really, really remarkable technology. The next part of the puzzle here in structural heart disease also revolves around stroke. Many patients, young patients actually, that come into this hospital and have a debilitating stroke, we find out they have something called a cryptogenic stroke, or basically a stroke that wasn't caused from AFib or atrial fibrillation, or a stroke that wasn't caused from plaque building up in the carotid arteries. So basically, it's a stroke that's occurred because certain patients, and actually 1/4 of all patients that we ever see, they have something called a patent foramen ovale, which is basically a hole in the heart. And for many of us, that hole never becomes a problem. But for certain people, that hole actually becomes a problem because they shunt blood, or basically they take blood from the right side of the heart to the left side of the heart, and it goes through the hole. And if you have little clots that come up from your legs and they go through that hole, where do they like to go? They like to go to the brain. And that can cause a debilitating stroke. And a stroke in, a 45-year-old is, that's a big event. So what we can do is we can actually go in and cross that hole and deploy a device to close that hole. And what that device would do is prevent you from ever having a stroke again. So this is also a very novel thing that we've been able to offer to our patients. And we work very closely with an amazing group of interventional neurologists and neurologists at our hospital to make sure that this device is something that could definitely benefit our patients. And another amazing aspect, you come in as an outpatient and you're home that same day. So that's the amazing thing about the structural heart interventions, is that the length of stay is so short. You come in and you get it done and you're out the next day, and you're basically back home doing what you want to do without a long recovery process. And then coming soon, and I'm very eager for this, is something called transcatheter mitral valve interventions. Like I showed you in that earlier picture of that echocardiogram of the mitral valve being replaced, this is one of the procedures where we can actually fix people that have severe mitral regurgitation. And basically what it is it's a procedure where we can go in and deploy a little clip across the mitral valve to basically stop that mitral valve from leaking so much. It was initially only indicated for people with certain mitral valve disease, but the FDA just last month recently approved it for all mitral valve regurgitation. So we're very eager to be able to offer this to our patients. And once again, same idea. You come in as an outpatient and you're discharged home, relatively quickly. And we are excited to bring this option to our patients very soon. So that's a whirlwind tour through structural heart disease. I know I covered a lot of stuff, but basically what I wanted to highlight was structural heart disease affects all of us, whether we're healthy throughout our whole lives and we take care of ourselves. It's just the normal wear and tear of the heart. And as you start to live longer and all of our American population starts to live longer, we're going to encounter more and more structural heart disease no matter what we do. And it's amazing that in the last 10 to 15 years, the only approach was surgical. So you had to go through open heart surgery. But now what we're finding is these transcatheter interventions, they are the future. And that's what I hope to see in the future, is that they become the standard of care. And these are something that we can offer to all patients. And you can come in as an outpatient and be sent home the same day. It's pretty remarkable that we can bring all these options to our patients. So I leave it to you guys for any questions, but thank you so much for letting me talk a little bit about structural heart disease. And if you guys have any questions or you need any consultation about structural heart disease, please do not hesitate to contact us at any time.
And we are taking questions through our chat feature. So if you have any questions, you can enter those. I do have a couple questions here for you, Dr. Mohan. You mentioned aging, but are there other risk factors for developing heart valve disease?
So yes, there are. But one of the unique things about structural heart disease is age becomes such a big risk factor. So as we all get older, it's just the normal wear and tear. But generally, normal risk factors for coronary heart disease or regular heart disease are risk factors for structural heart disease. So things like high blood pressure, high cholesterol, diabetes, heart failure, dilated heart, atrial fibrillation. All of these things end up being long-term risk factors for structural heart disease. So if you want to do everything possible to reduce your risk, it's the same as what we always tell you. Keep your blood pressure under control. Don't develop diabetes. Take a cholesterol medication. Keep your cholesterol down. Exercise, diet. All of these things will reduce your risk. But if you live long enough, I promise you will develop some form of mild or severe structural heart disease. And it's just a natural progression of age.
Another question, I think you had mentioned it when you were talking about the TAVR procedure, but some of these other procedures, do patients notice a difference in how they feel after all the procedures that you discussed today?
So I think that's what really drew me to structural heart disease is it's just amazing how much better you can feel in one day after these procedures. Because you probably, if you came in with aortic stenosis, for example, you've been living with that for a long time because it doesn't just happen overnight. It happens over a course of 10 years. And so you may have been, walking 2-3 blocks and then gradually that's gone down and down and down. After this procedure, if you present early enough, you will feel back to how you felt when all of this first started. So it's instant gratification for us. It's really amazing to see patients follow up and see how much more active they are and how fast they recover. Obviously, some of these procedures are indicated for very sick people, and we are doing them to make them feel better, but also this field and these interventions have been shown to help people live longer. So it's an amazing thing. And if you present early enough and we catch things early enough, the outcomes are amazing.
I have another question here. If heart disease and stroke are hereditary, what tests should I have my doctor do? I'm 62 and have no symptoms.
So there's a lot of different options. I think the normal risk factor profile with basic lab work is very important. If you have a strong family history of heart disease, I would definitely check a lipid panel at least once a year and keep your LDL or lousy cholesterol as low as you can get it. Also checking things like something called an A1C, which is a marker for diabetes, and blood pressure control. Very, very important. People kind of blow it off, but blood pressure over a long period of time is one of the biggest causes for a weakening of your heart. And then as technology has improved, we're excited to offer, and we're going to start offering more and more patients at McLaren, is cardiac CT scans. So if you have a really high risk profile and your cholesterol is, borderline, but it's not super high, you can undergo something called a coronary calcium score. And that can tell us if you have any calcification in your coronaries, which is a marker of plaquing in your coronaries. And that could tell us, you definitely have plaque developing, and we got to be aggressive with all these risk factors to get that stuff under control.
Great. A lot of people are wearing smartwatches or using smartphone apps to try to track their health. Have you had any referrals as a result? Or if someone uses these devices, what should they look for?
I have. Some people think it's irritating because these watches are kind of over picking up a lot of things, but I find it amazing because this is only like the first and second generations of these devices, and they're still very accurate. And specifically in picking up atrial fibrillation, which I mentioned earlier, is one of the biggest causes of stroke. So if we're able to pick up things like atrial fibrillation early, that really helps us to prevent a debilitating stroke later on in life. So I encourage my patients, if you have a smartwatch, I wear one right now, wear it and take interest in your heart, take interest in what your resting heart rate is and what happens when you exercise. For me, it's just more data that I can use to help figure out the puzzle when I see a patient. So I think as technology improves, that's the future, and we're really going to we're going to get away from these expensive heart monitors that we're forced to use, and more of our population is going to be able to afford these, wearable devices.
Great. And it's the last question that I had. So as I've been a nurse for a very long time, and I can attest to how far technology has gone across my career as well. So I think you're right. The future is bright, as you said. So thank you. Yes, thank you so much, Dr. Mohan, for sharing this information with our audience. And I want to thank everyone for tuning in and joining us today, and hope everybody has a great day.
Thank you so much for having me, and please talk to your doctor if you have any concern regarding structural heart disease or any other thing. We're always here for you guys, and please call us at any time.
Great. Thanks again, everyone.